I'm Dr. Gary Brauner, a fellow of the American Society for Dermatologic Surgery, and it gives me great pleasure today to be speaking to one of the icons of dermatologic surgery, Dr. Lawrence Field. I am old enough to have been through the beginnings of dermatologic surgery, having trained in the era before there really was anything other than Neolithic dermatology. So I'm going to go back to where I started during my residency from 1968 to 71, where I trained at the Mass General Hospital, which was at that time considered one of the world's foremost institutions of teaching of dermatology, which means teaching of dermatologic surgery as well. And I can tell you that at this foremost institution, what our dermatologic surgery consisted of, with the exception of dermabrasion, which one of our attendings liked to do and would teach us, and subcision, which one of our attendings was a pioneer of and liked to teach us. Apart from those two procedures, the only thing that we did surgically was to do punch biopsies. And even those punch biopsies did not have sutures placed in them. We did no excisional suture surgery. Everything that had to be done on the skin that involved surgery, essentially, was passed off to plastic surgeons. There was no such thing as what we know today is dermatologic surgery. And the reason I'm making this such a prolonged introduction is because it would be impossible for today's young dermatologists and dermatologic surgeons to have a concept of that, because it's so ingrained now in their training that they are not just dermatologists, but dermatologic surgeons. You can't envision a day of true dinosaurs when all we did was punch biopsies. But that was 1968 to 1971. And your career precedes that. What was it that made you start off in doing more aggressive surgical procedures? What happened to you in terms of your training?
Well, I've been at surgery now 75 years. I helped my father, who was a proctologist, do dressings and fistulae when I was a very young man on male patients. I went in the Marine Corps, came out, and when I was in medical school, the situation was exactly what you say. And I was at the University of Wisconsin, 51 to 55, and I was Dr. Fred Mose, who was then unknown. I was his gopher. Field, go for this, go for that. So in the very early years of micrographic surgery, I was there. That was 51, 52, et cetera. When the minimum age, by the way, was 75 cents an hour. And that's what I got paid at the University of Wisconsin. I went and I interned in Kansas City, Missouri, where I met two very influential people for the future of dermatologic surgery. One was my friend, Dr. Chandler from Arkansas, who was a Marine. I was a Marine. He was nice to me, and I was doing all the dermatology. His results in many ways were much better than my curette and desiccation, so he taught me, my fellow Marine. His boss was Dr. Earl Paget of the world-famous Hood Paget Dermatome, also in Kansas City. So when I was first-year resident, I was using dermatomes to harvest foot-thickness skin, which was unusual. Another person at that career time was Ralph Lucard, who gave the first papers at the Academy, surgical papers, and that was on dermabrasion. So I early learned with serrated steel, not diamond phrases, not even brushes, serrated steel to do dermabrasions from Dr. Lucard. Everybody's deceased by now. So that was early. And then I continued in Kansas City with Dr. Paget and with Richard Sutton, who wrote the first textbook in English as an American on dermatology. We used to give cobra venom injections to patients with herpes zoster in those days, a long time ago. I was educated and slated to become the dermatologist for the new 4-year medical school in Columbia, Missouri. And I went there in 1958. I did renal biopsies. I did kidney biopsies. I did other biopsies. I learned and did flaps. They were the first ones probably in Columbia, Missouri. But I got bored. I went to Saudi Arabia. I was very fortunate to have been selected, and the faculty for the Arabian American Oil Company in 1959, when I went, were 20 Americans, all specialists. Everyone helped each other. So I scrubbed with the general surgeons. I scrubbed with the OBGYN with hysterectomies and vulvectomies. I did cataract surgery, simple cataract extractions. When the ophthalmologist checked them with a slit lamp, and that they were simple, because he was the only one doing them in a country of a couple of million people. So the Bedouin would come in by camelback early in the morning. We'd put him on a cot, put the eye to sleep, cataract incision, slip it out, put in a suture, and away they'd go on their camels. Absolutely amazing. Never see them again.
Let me ask you a question about doing these procedures and resistance from doing these procedures. When you were in Kansas and you were learning how to do dermatomes, was there any resistance from other physicians around you?
The answer is no, because I was with Dr. Paget.
You were working with him privately then?
Well, no, he was at the Kansas City General Hospital, which is a charity hospital, and Dr. Chandler was the chief surgical resident, destined to become a plastic surgeon, and I was there.
So no one said anything about the fact that you weren't a plastic surgeon?
They didn't dare.
Doing these procedures?
They didn't dare. The big boss was there.
And when you went
I was under his wing.
When you went to Missouri, you were starting off by yourself, though. You were starting with someone new. You were doing surgical procedures there. Was there any flack from anyone around you there?
I was only
saying,
there
"Wait
a
second,
year."
What was he doing?
No.
So there you had no resistance either. When you were in Saudi Arabia, you were needed, obviously, to do all these extensive procedures. So there's not going to be any flack from your compatriots around you.
No, but I scrubbed with them.
They're teaching you how to do it. Right.
Right.
So they welcomed you rather than being antagonists saying you shouldn't be doing this. You're just a dermatologist.
Right.
Okay, so now let's go on. You've been unopposed all these times of doing this
So then
surgery that no one else is doing in the United States.
Then I left Saudi Arabia and I went to Stanford, spent a couple of years, worked at the VA hospital, and I cataloged all the surgical lesions which were visible. I'm sort of famous for this. And I denuded 1,000 or 2,000 mentally ill veterans of their visible tumors. I had an ambulance going back and forth from the VA hospital where they lived, to Stanford hospitals, to the surgeries. And again, the person that ran the mental hospital sort of gave me carte blanche to take care of these people. Nobody had ever seen them. They were just laying around growing tumors. So I had a wonderful time for a couple of years.
There were no plastic surgeons there who saw what you were doing.
Nobody
who complained
gave a
about it.
damn what happened to the old fellas at the veterans home in Palo Alto, California. Nobody had ever seen anybody. So I had a wonderful time. And my partner at Stanford didn't like surgery, so I had an even greater time. Then I went into private practice, and I immediately, you shouldn't do that, you can't do that. Initially, I had surgical privileges at the local hospitals, etc. Those were gradually removed, and then new administrators came along, and they wanted surgical credentialing, which of course I didn't have, so those were removed. So that's a long fight.
But that was the first time that you had basically faced antagonism from other specialties.
When money entered the equation.
So all these other things you were doing for people who were indigent or on camelback or whatever, who required the care, but once you got into a community where there was a competitive atmosphere, then the gauntlet was thrown down. But
yeah, or they were at the University of Missouri, and they came to that clinic, and I was the only one who could help them. So there was not to my knowledge.
No, so how did you continue to do the kinds of things you wanted to do?
Well, it was my legal right, and I did it, and I went to great extent to learn things. I went to London to learn blepharoplasty from a fellow named Silver. I went to Detroit to learn breast augmentation. The breast is an organ of the skin. Matter of fact, Dr. Lucart, who taught me dermabrasion, was then in Santa Barbara. We went together to different courses of the American Academy of Cosmetic Surgery, which began probably 1962 or 3. And so at that time, my great mentor of my life, Richard Webster, who founded that, and I was one of his proteges. There were 3 dermatologists that learned from Richard Webster: ENT, general plastics. Wonderful gentleman in Boston. And that was Thomas Alt, still alive, hair transplanter, now deceased, and his son still does it. I'm sorry, I blanked out. But all of us learned from Richard Webster.
Dr. Stowe?
Blue Stowe.
Right.
Blue Stowe. We all went to China together with Dr. Webster in, I think, 83 or 4, right after Mao Zedong died. And all of these were learning experiences for me. I still learn.
So this preceded the ASDS by about a decade, the Academy of Cosmetic Surgery, is that right?
63 to, yeah, I'm
so
not sure.
there was no ASDS. So you're doing this surgery. So you're doing this surgery with this training that you had. You were doing it as in your office facility?
Correct.
You couldn't do any of this stuff in the hospital, was that it? Because they
Eventually, no.
cut everything down?
That's correct.
Were you still getting flack from the community plastic surgeons for doing it in your office?
Well, when I first started, there weren't any plastic surgeons there. When the first plastic surgeon came, he told the ENT man, "You can no longer do noses. I'm here." He told the ophthalmologist, "Whatever you do in the eye, I should be there." And he told me I shouldn't be doing what I'm doing.
But you were doing this in your office.
In my office.
You were able to continue doing that. As you continue to work in your community, in your own private practice, after this initial difficulty with hospital privileges and the antagonism of the plastic surgeon towards others doing so-called plastic surgery, did you do anything to basically try to influence the community of other physicians into understanding what a dermatologist was capable of? Or did that sort of precede your efforts?
Well, those that were my friends, and I did good work. They continued to send patients. I'm not sure how much flack they got from the others. I never was unable to pay my rent, so to speak. And I continued getting educated. I had to travel to do that. And it was a day when the Academy of Cosmetic Surgery had workshops. They had workshops in breast augmentation. They had workshops in facelifts. Dr. Webster was the proponent of short flap rhytidectomies. I spent parts of 2 years with him. I also was Dr. Julius Newman, who's an ENT facial plastic. I went to him for parts of 2 years. This was all the 82 to 84, 85 period. And I learned a lot, and I did a lot. And I think the first publications in our literature were by dermatologists on rhytidectomy or mine, on eyelid surgeries, blephs, etc., are mine, in the Journal of the American Academy of Cosmetic Surgery. So I was busy learning. I always enjoyed learning and being with people who could teach me.
Did you attempt to spread your knowledge of these advanced procedures, knowing that other dermatologists were doing almost nothing? Did you attempt to approach the American Academy of Dermatology to teach their courses or to encourage them to expand?
I think they
in dermatologic
approached
surgery?
me. I think, I can't tell exactly what came before what, but it was a very volatile period of my life. And when I was doing these surgeries, then Sam Stegman, who was at UC San Francisco with Dr. Tromovich, and I think Dr. Glogow was young then, and they heard about what this crazy guy was doing up where I was. So I was invited down to give some lectures, then invited to do surgery. I went on faculty at UCSF probably 76 maybe. I was there a quarter century. I ran the advanced reconstruction clinic there for the residents. Everybody learned from me. And then the fellows There are fellows here. Next year's president of the Academy of Dermatology, Abel Torres, was a fellow at UCSF when he came to my office to learn very advanced surgery. So they did that. Alistair Carruthers was there. Roy Grecton wanted to be there, but I was already gone. So a lot of people came to my office to
So
learn.
this is about the same time the ASDS was about to be formed, or was being going to be formed.
Before that, or at that time. So I always enjoyed that. They lived in my home. I never charged anyone anything in my whole life. To learn from me, nobody's ever paid money.
When you were doing the teaching at UCSF, you were doing that, though, in a hospital setting.
Clinic.
Well, it's still part of the hospital.
Yeah.
Were you getting any flack from competitive groups like the plastic surgeons
Well,
about the kind of surgery the dermatologists were doing now?
Dermatologists did the way it should be done all over the world. They had a visual tumor conference. Still runs. That was organized by Ted Tromovich, father of fresh tissue technique. All visible tumors came through dermatology. There was then a triage of those tumors by group. So we had general plastic, facial plastic, eye, radiotherapy, immunotherapy, but all the different disciples or disciplines were around the table deciding what is the best course.
So they had a positive integrated approach then,
That was wonderful.
not a competitive approach.
I think Sam Stegman was the one who heard, and Sam is the one who talked to Ted Tromovich, and that's the first contact I had, because Sam was sensitive and aware of some of the things that I was doing.
So having an integrated approach then was obviously a positive scenario for you.
All dermatology services should run with a visual tumor conference where everybody's invited so they can know our skill. We had dermal pathology there. They always had it. We have things nobody else has. In liposuction, I have shown microscopic slides of fat. Plastic surgeons don't know what it is. Okay? So there's a lot of things that we fill the gaps that are necessary.
When did you end your private practice in San Luis Obispo? In
1988.
1988. And after that, you became a roving ambassador of dermatologic surgery all over the world?
Oh, I was doing that before that. I think I went with the newly formed ASDS in 1976, I believe, or 79. The formative meeting was in Morocco with 2 buses of weird people from around the world. I met a lot of nice people there, including especially some very famous German professors of dermatologic surgery who did big things. And I there began and funded the International Traveling Chair of Dermatologic Surgery, which itself visited about 60 countries. I left the ISDS because of ethical concerns, with which I didn't agree, along with significant amounts of money, which were never accounted. And that has never been replaced, and that rupture never been repaired. I turned to the ASDS as a renowned ethical organization and sort of transferred that international teaching under ASDS auspices in the guise of the International Traveling Mentorship Program, which exists and expands and will be a wonderful thing.
What was it like to be away from home, running from country to country? Were there times you got tired of the running back and forth, or was just a constant stimulation to you?
My
to be
body
able to
got
teach the
tired, my
people?
mind not.
And when you went to these countries, what, besides being able to teach people how to do things, what did you see? Because their countries then, if you were teaching them these things, were probably at the same point that Gary Brauner was in 1970 in his own training program in Boston. What did you see in their programs for dermatologists? Were they also in a place where they were unable to do dermatologic surgery or had no idea of what dermatologic surgery was all about?
The first time I went to South Africa, which was, I don't know when, we took oranges, made incisions in the skin, God, an incision, and then took an undermining scissor under the thickness of the skin to undermine it. Nobody had ever done it. And if no matter how far back you go, nobody is really prepared. At that time, nobody is prepared for what this listening audience will know as dermatologic surgery. It didn't exist, and I felt it was my obligation, if you will, and my great privilege to take them by the hand and say, come take this step, and now take this step, and take the scalpel, hold it this way, and hold the skin when you're making an incision this way. Now you puncture with the scalpel, and now you make the incision and move your... That's the kind of mentoring people need surgically. It's very precise. You cannot see it in a photo. You cannot have a video of it. You have to sit there hand on hand and show them. And they never forget that. They never, ever forget. You, whoever you are, from whatever country you come, held my hand, teaching me the right way to do things. That's a very, very special thing. It's a privilege to do that. So even today, I never get tired of it. I'm going later this year to countries nobody's ever been. I'm going to Cambodia, and it was, they killed 1 million or 2 million Cambodians recently. I'm going where nobody's ever been with my skills, and I'll just take them by the hand, first step. They'll love it, and then we'll go forward with it.
Now, do you encourage them when you go there also to not just maintain their skills, but try to teach it to their fellow countrymen who are doing dermatology as well?
Well, that's what the world needs. The world needs that expansion of dermatologic surgery, and it has to be.
The old do one, see one, teach one.
That's great.
That's the only way it's going to spread.
That's correct.
Are you seeing in certain of these countries obstructive things from competitive specialties?
Oh.
Also that.
You want the old days or the more modern days?
Both?
Old days. Barcelona, Spain. Can't even give you the year. Plastic surgeons blocking the entrance with their bodies. He can't come in here. He's not a surgeon. Took the dean of continuing medical education to come from his office because it was arranged through the dean's office, who's superior to all the plastic surgeons and everybody else, saying, get out of his way. He's going to go in to teach. And that was it. As recently as 2 years ago, I was in Amman, Jordan, flying from Bavaria, teaching in Bavaria, to Amman, Jordan, invited by the Department of Dermatology. And I was flying on a weekend, and over the weekend, 2 plastic surgeons took away all surgical privileges of any type for all dermatologists. So when I got there, that was their rule. It was on a weekend, and then it took time to reverse it, and it was reversed. But when I was there, I did no surgery myself. I was not allowed to put on gloves. That's within 2 years. And that doctor in Jordan is a mentor in the program, and a wonderful one.
So it persists throughout the world still.
It's
Same
a
kind of
big
mentality.
struggle. Probably, yeah, everywhere it's a big struggle.
But again, if you're doing this, you're not allowing people to appropriately deliver care to people who need it.
They don't care. As a group, I know wonderful plastic surgeons. Plastic surgeons taught me. I mean, my big teachers were plastic surgeons. That's true. ENT, plastic, and facial plastic, they're the ones who taught me. Much of what dermatology has truly, from the old days, came through me, but it didn't originate with me. I learned from many, many people. I traveled for the learning. I couldn't learn in this country. The doors were already locked, and it was easier then than it is now. It's really compartmentalized now. which is sad because we have so much to teach them. But things are as they are.
Who were the greatest positive influences for you as your teachers and inspiration to go on and do all of these wonderful
Richard
things you
Webster,
do?
number one. Richard Webster is the first honorary member of the ASDS. The second one is Pierre Fournier. So I happened to be in 1977. I went to a meeting in Paris when the Fishers from Rome, who discovered modern liposuction surgery, had come to Fournier's office to demonstrate it, and we did it, and Pierre was there, and he has been my friend all these decades. And he was an aesthetic surgeon in Paris. Liposuction has been the avenue by which dermatologic surgery has spread because it's something every dermatologist should do. Lipotransfer should be part of every dermatologist's armamentarium. You must be able to do liposuction to transfer a little fat. I've been saying that for years, why these people struggle to find one more person to do a full-face laser abrasion when you've got all these fat people that can be improved. And it's such a huge market, and it's so much there. It's such a relatively simple procedure, no matter how much people glorify it with freezing it or lasing it or whatever it is. It's still basically a very good procedure that everybody, even the plastics people, weren't doing it. Okay. When I first was doing liposuction surgery, plastic surgery had officially said it was no good. Okay? And the first presentations I gave in the city I lived were given to psychiatrists at the local hospital, to psychiatrists because they thought it would help their patients with obesity problems. Okay? That's the first presentation I ever gave on liposuction. Eventually, Rhoda Narons of New York, who had the first liposuction training program at any university in the world, to my knowledge, she and I ran international symposia for 5 consecutive years in the 80s in Edinburgh, and I even forget where, but she and I were co-chairs for that. That was the time that Jeff Klein, who was a pharmacologist and an internist at my university at UC San Francisco, and Sam Stegman and I were co-chairs of a program at Lake Tahoe which Dr. Klein attended. And he was sitting in the front row, and I was talking about liposuction and showing some cases. And he said, is there anything to that? I said, young man, it's the greatest thing I've ever done. People are so much helped, and they're so happy. And he went ahead to be immortal by giving us a tool which we all use, should use, the principles of which have been refined with surgical tumescent anesthesia and bi-level surgical tumescent anesthesia, which I described a decade and a half ago. And it continues to surprise me how many people don't do it. You can't go to some countries that everybody doesn't do it. But that's a matter of education.
Who else besides Webster and Fournier in terms of your major influences?
Well, Julius Newman, who was facial plastic, ran the Department of Cosmetic Surgery at the University of Pennsylvania. He was called Dr. Nose. I never did a nose in my life, but I learned a lot of tricks. I scrubbed it with him, and he was doing suction-assisted rhytidectomies. 82, and I was there, because I have photographs of the first cases I did in 1982. We had a cannula and a little projection on the top of the cannula, which was clear plastic, so we could see if fat was flowing because we didn't know where we were. So as a safety feature, that was there, and as we got better, it disappeared. But that was 82, and I have photographs from 82 and 83 of doing that procedure. And it was a great influence on me, especially their live surgery clinics, which I attended. The other thing which happened in dermatology of import was the organization of Schering's graft and flap. It was a traveling symposium. And the plastic surgeons from NYU and Dr. Perry Robbins of NYU, then of NYU, and myself used to travel in different states to teach dermatologic surgery and Mohs surgery. And I learned a lot from them. Dan Baker of New York, who was a very famous plastic surgeon, and Steve Cohen, who was associated with him. So we all traveled together. I had the chance to bounce ideas off.
You noted that you wrote the first publications by any dermatologist on blepharoplasty, rhytidectomy, liposuction, bipedicle island flaps, macrochyloplasty, and bilevel anesthesia. What is there any one or two of the things that you've written about or taught about that were unusual or unique that you're proudest of?
I think the thing which will help the most people, both doctor and patient, is learning bilevel surgical tumescent anesthesia, because it makes it so rapid, so safe, so bloodless, and so injury-free.
Can you explain that for the audience that will watch this?
Well, it's a matter of when Dr. Klein put forth his Klein formula, which I think was 85, something like that. And those of us who did liposuction, I did general anesthesia in my office, spinal anesthesia in my office. That's all gone away. But the principles that Dr. Klein enunciated and evaluated are adaptable in all kinds of surgery. And we're not the only specialty that uses it. Anyone doing surgery, essentially, unless they have to be asleep, should know those techniques. But basically, one is using a blunt instrument. Everything I do is blunt. I'm not a sharp incision man. But if you have a thin cannula and you can make a little perforation in the skin, perforate the skin, then take this cannula and have it go right under the skin, right like that, right subcutaneous. And then inject your surgical tumescent anesthesia on the way out. And you learn how to do that serially. So I can do it here, and then I can do it here, and then I can do it
So
here.
you're fanning it, yeah.
You fan it from different places on the face. With surgical tumescent anesthesia through 3 ports, little ports, through which I make a little, Pierre Fournier described a pocar. It's like an ice pick, which leaves no scar to go through. And then one can take this and fan it, put the areas you want to sleep. And I can do that in 120 seconds, whole face, including upper lip, nose. Nose is a little bit difficult right here because there's no subcutaneous space, but basically. So if a patient has a big cancer on the nose, I don't put the nose to sleep. I make a little puncture wound up here, thread this blunt instrument, which doesn't hurt the patient, right down, do that side of the nose, do the tip of the nose, come to this side of the nose in a matter of seconds. Then, as all that continues to work, I will do the second of the bilevel anesthetic, which is your standard anesthetic, higher concentration of epinephrine, higher concentration of xylocaine into the incision lines. And I'll do that serially. So where I first put in the deep level, is where I'll first start putting the skin to sleep on the top. And then when I start the procedure, I'll start over here where the anesthetic's been in the longest. And I'll do the whole area. And if I do a large flap, I may have to use a cautery once, maybe twice. And that's almost always in just the middle third and in deep.
So you had almost bloodless surgery then.
Almost bloodless.
Are there any techniques that you tried or used that you were very unhappy with? You said, I'm not doing this anymore.
Well, I've made more than my fair share of errors. Probably the things I've regretted were doing more aggressive surgery on lower extremities, which we all know is a problem. I'd be hard put. I'd be hard put to look for something. I wrote something once, and it's up in a surgery in Athens, Greece. T-smack cubed. Think of T-rex, XXX. The big T is think. We heard this morning from Dr. Goldman, who was giving his lecture. The most important thing you do is think and plan. So that's very important to me. Think, then scrub, then mark. Because if you mark first and then scrub, it's gone. Think, scrub, mark, cut, close, cover. T-smack cubed. And that's everywhere I've been. I sort of leave it. Because it's true. The most important thing we do is think. And I'm very, very, very careful. There are twice as many lawyers in the state of California as doctors. And it's a good thing to think.
Is there anything in this interview that you want to have preserved for posterity that I didn't ask you? Then I'll ask the question. I was thinking of asking you people you had trouble with, but that's wasted. We don't want that. We don't want to have who gave you hard times. We only want the good parts.
Well, I've had a lot of that too. Well, for any of the audience who is going to embark on a new thing, you think, do a lot of thought, try to go with someone who knows how to do it. I had people come to my office from all over California. If they had California licenses, they could scrub with me. I opened my office, if I were doing a cancer or whatever, to the referring doctor. Doctor, if you want to come, your first assistant. Come with me and learn the way I do. We'll do it together. You're going to be taking out the sutures if they came from 100 or 200 miles away. So learn how they're going in, and I'll tell you which ones to take out. I remember one doctor, Charles Fishman, you know him personally, he's in my city, and he referred a patient with a terrible lip to me. I did a vermilionectomy, and he came and he scrubbed. And he finished, and he said, geez, if I knew it was that simple, I wouldn't have even said it. I would have done it myself. That's, there's a lot of truth to some of that, but I think it's a good thing. If you're going to embark on a new technique, new procedure, go find someone. And remember, if you refer a patient to a specialist, it's your ethical right to go with your patient to be there at the time of the surgery. It's an excellent way to learn. And I always tell people, the more you know, the more you will learn. Bill Coleman was this morning talking about reading articles about closing big holes. He said, well, really, I sort of look at the hole and I look at the closure. I don't have to look at anything in between. Yeah, but you're a very, very, very experienced senior surgeon, and I know exactly what you mean. But most people, it's a serial step-by-step procedure, and you have to think out each step in advance. And if you think there's trouble, don't do it. And I learned a long time ago from, I can't remember who, if your stomach's not happy with what you're going to do surgically, don't do it. Your stomach is smarter than your ego in your head. Your stomach will put a no up when you may not do it consciously yourself. So listen to it. It'll know more than you know. Because even if you're comfortable, you're going to have trouble. We all have trouble. I mean, I might have done something 1,000 times, and the 1,001st time have trouble. But certainly when you start, and if you get in trouble, the attorneys, and I've been an expert witness many times, the attorney will be asking you, how did you learn it? From whom did you learn it? How many did you see? How many did you do? That's part of the routine questioning. So it's a wise thing.
Thank you very much.